we don't have to read the bio for Sam, and of course he always gives wonderful talks, so we'll thank him for that.
So Andrew Healy gave a talk on DCD hearts last year. Andrew, that's correct, right? Yeah, at this meeting. And arising from that, there was a number of novel, innovative concepts that we had to kind of get our heads around, and I think from a practice, policy, and research point of view, need to answer. And I'm here to kind of try to make some sense out of some incoherency in this field. So I show this slide a lot. Over the last 16 years, we've done 18 leading practices in deceased donation with this community and its collaborators, and many of you have been part of this and pulling all together. When you reflect on it, 40% of them, 7 out of 18, are directly related to death definition and determination. Mikhail mentioned this paper. This is the paper that I'm most embarrassed about arising from our health policy work, because it was only until I went to a Transplant Quebec meeting in March that Mikhail showed me his flower pot analogy, showed us his flower pot analogy of flow, perfusion, and function, that for the first time I really truly understood it. And so it's worth repeating because it helped me a lot. So these are two trees. One is clearly alive and one is clearly dead. And the question is, what is the difference between those two trees? And again, it's the issue of flow versus perfusion versus function. And we would agree that the leaves on the trees are a representation of neurological or neuronal function. And if you don't have leaves, there's no function. And as Mikhail has said, that flow, this was a misconception, that flow equals perfusion equals function. And we didn't even get into, just because you see opacification of vessels doesn't even mean there's flow. It's just opacification. But this was a misconception. What is true is that function requires perfusion and perfusion requires flow, but flow doesn't equal perfusion and perfusion doesn't equal function, yet we measure function on a clinical exam and we measure flow on an ancillary study, and that's exactly what Mikhail is trying to unravel for us. So what is the difference between these two trees? The living tree needs an underground water table to provide water that can go up through the root system to feed the leaves. And the flow is the water system under the ground. The perfusion is the root system going to the trees. And function is the leaves. And the thing that distinguishes life from non-life is two things: metabolism and replication. Metabolism, which is what we do in the ICU all the time, delivering oxygen and nutrients to cells, cardiac output, oxygen delivery, and replication, not just cellular replication, but replication from the DNA to the RNA, from the RNA to the protein that builds building blocks that create structure and function of cells and bodies. And currently we have two dual concepts of death. One is the arrest of the brain, which means it could be because there's no flow, or it could be there's no perfusion, or it could be there is no function, but there still can be perfusion and there still can be flow. And that's what Mikhail's work is going to help us understand better. And then on the other side, we have, before it was cardiac arrest, and now it's circulatory arrest, which means there is no flow. And if there's no flow, there is no perfusion to any organ, including the brain. And if there's no perfusion and no flow, there is no function. So when we did this work that established the DCD framework in Canada, we said in this report that death after cardiac arrest is based on cessation of circulation, and permanent means it will not resume spontaneously, and Sunny's study has helped us answer who is at risk for resuming spontaneously and how long you have to wait. And it will not resume through intervention, meaning there's been a decision not to provide CPR. This is our typical DCD process in Canada. After death and organ recovery, there's two ways. You cold storage and you allocate and transplant, or you get onto an ex vivo ex situ organ perfusion system that provides oxygenated circulation to an organ isolated from the body. 30% of our donors in DCD, it's been responsible for the largest quantitative increase in donation for all organs except for the heart that has not benefited from the advances in DCD because the heart has stopped, and therefore previously you couldn't transplant that heart because from withdrawal to circulatory arrest there's a hypoxic, hypotensive phase that leads to a cardiac arrest and leads to an ischemic, anoxic heart, and previously we thought we couldn't reanimate that. And transplants in Canada currently after brain death, the majority of them are Ontario, Quebec, Alberta, and BC, about 160 per year in adults, 23 per year in children. If you look at wait list deaths and withdrawals from the wait list because people deteriorated and got sick, it's about a quarter in adults and 30 to 50% in children. So there is a compelling human story about trying to improve heart transplantation. In order to transplant a heart, Stephen Large, who is the pioneer in Cambridge, said the heart must beat again. So how do you get back from an anoxic, ischemic, arrested heart to a pumping heart? You can do that in the body of the transplant recipient. Clearly, it has to occur in the body of the transplant recipient. You can do it outside the body, ex situ, ex vivo, then transplant. You can do it in the body of the dead donor and then transplant. Or you can do it in the body of the dead donor and then ex situ and then transplant. And this is the direct procurement and perfusion system in which it is no different really than what we currently do. And this is the way they do it in Australia, in which, and it's led by Peter McDonald's program in Sydney, and basically after the 5 minutes of circulatory arrest, they remove the heart, put it on an ex vivo, an ex situ pump machine, and then reanimate the heart, try to measure some variables that predict function, and then transplant the heart. This is the only form of DCD hearts that is done in Australia, and it's done in the UK as well. The next one is to reanimate circulation in the donor's body after death, so-called thoraco-abdominal normothermic regional perfusion. What is that? It's effectively, for an intensivist, it's donor ECMO after death, donor ECMO after a cardiac arrest in the unit. And there is lots of European data that supports how well it will work to improve transplantable graft function because you are reinstituting oxygenated circulation to those organs, either the abdomen in isolation or the abdomen and chest. But what do you think happens when you put somebody's body after death after cardiac arrest on donor ECMO or NRP? The heart's going to start beating again because you're not only resuming oxygenated circulation to the body and the organs, you're also resuming it to the heart. So how can you still be dead in this paradigm? You're dead because what the surgeons do before they start the ECMO machine is that they ligate the aortic arch vessels that feed the brain. So they're basically restarting oxygenated circulation to the body, precluding brain blood flow, and therefore fulfilling one of the requirements to be dead on a neurological basis, somebody who started to be dead on a cardiac and circulatory basis. And this is data that was given to me by Phil Walton. The data to date, there is almost 150 transplants worldwide, not enough to really compare the difference between DPP that's in Australia alone. And the reason they don't do NRP is because in Australia, DCD said you're dead after your circulation stops, and if you restart circulation, you're no longer dead legally in Australia. In the UK, they have both forms, and the reason they can do it in the UK is because they clearly articulated in their framework for death that death is about the loss of consciousness, brain death, that can be secondary to a primary brain injury or after a cardiac arrest, which arrests circulation to the brain. That's why it's okay to do NRP in the UK. So we said cessation of circulation will not resume spontaneously or through interventions, and these are the words that we use. We used to call it non-heart beating, no heartbeat, meaning no circulation. Heartbeat opens the aortic valve. We used to then call it donation after cardiac death, and then we realized, well, it's not really death of the heart. Then we called it donation after cardiocirculatory death to combine to both. Now we're calling it donation after circulatory determination of death, a more accurate term, Laura Hornby, who gave us this or advocated it. And it's death based on the loss of circulation, but we never said where that circulation has to be arrested in order to still be dead. Where is it supposed to stop? The whole body? The chest and brain? Anywhere except the brain? And so in our context, there is an incoherence around what our concepts of death that we said are versus the impending NRP implications for what that means and what we accept. So we had a meeting, a collaboration between Trillium and CBS. Last year, Andrew reported about this. And basically, again, the clinical scenarios in DCD is a bad prognosis but not dead, and a decision to withdraw. Most often, almost uniformly comatose, awake occasionally. That's practice in the UK, Australia, and Canada. A distinction in Canada is that heart DCD would also apply to medical assistance in dying, and the principal difference is they have a normal brain, so any issues around blood flow or reinstitution of brain perfusion after death is a magnified issue in somebody who starts with a normal brain. We did a survey led by Ian Ball and Kimmy Honerman of the public and the professionals. We will clearly admit that it's very tough to think that you can get the nuance between direct procurement and preservation and NRP and get a public or professional understanding in a survey. So I'll brace it with that. But generally, the results of both surveys were positive acceptance and support for DCD heart donation and transplant, a drop in support from direct procurement to NRP, but still strong support, no significant interprovincial variation, Alberta with a trend towards more caution, but supportive does not mean no concerns, knowledge, ethics, complexity, setting back gains in donation barriers. In our community, it's really important to maintain this firewall of practice and policy around death between transplant, who don't care for dying patients and have no role in the determination of death and legally cannot participate in that, and those who care for dying patients, the end-of-life care providers. What worried us prior to the meeting, heading into the meeting, and our steering committee, Andrew and I, and Lindsay and Laura and Sylvia and Clay and Jim and Janet McLean, what really worried us going into the meeting was the following. How would the community respond to restarting body circulation after death when you said they were dead after you stopped the circulation, restarting the heart in the donor body, and how would the surgeons feel about the complicity in death by ligating the aortic arch arteries in the operating room for post-procurement? And this was an interesting dynamic in the room. Stephen Large, who is the surgical innovator for NRP in Cambridge, was there, and Dale Gardner, who is the medical lead for donation and an intensive care doctor in the UK. Many of us know him, and he's been a great collaborator with us. And the question came up, why do you clamp the aortic arch vessels in heart NRP? And Dr. Large said, listen, the patient's already severely brain injured and comatose. Then they had 5 minutes of a circulatory arrest. They are irreversibly dead. The reason I clamp the arteries is to prevent any sympathetic discharge from the brain that affects graft function. And Dale said, whoa, wait a minute. That's not why we want you to clamp the arteries. We want you to clamp the arteries to prevent brain perfusion, and you're doing it to keep them dead, permanently dead. And so there was this disconnect in the UK between the transplant group that understood things in one way and the donation group that understood things in another way. And this was illuminating for them. So they went back home. So one of the key outcomes of this work that's been submitted to CMAJ is that around death determination, there was really variable surgical discomfort, not really a lot. Some surgeons felt a little icky about it, but others didn't have a problem with it. In that room with neurocritical care experts, ICU experts, donation experts, ethicists and lawyers and public and patient reps, in that room, that group did not have a problem with restarting circulation after death. They didn't have a problem with restarting the heart in the body after death. They didn't have a problem with the surgical act of ligating the vessels. What they had issue with was tell us that you're sure when you ligate the vessels, it achieves what you said it was supposed to achieve, which is no brain perfusion. So when Stephen Large and Dale Gardner went back and we urged them to clarify that there was no brain perfusion, because there are anatomic abnormalities of the aortic arch in vessels. There might be an aberrant subclavian that you can miss, other things. So they went back, and their next case was a 43-year-old with a vascular brain injury, consent to heart DCD, ligated the brachiocephalic trunk, the left common carotid, and the left subclavian were ligated, blocking brain blood flow, and then normothermic regional perfusion was started. Instead of just clamping the arteries of the arch, what they did, in fact, was open the cephalic ends, the head part, the distal ends of the arch vessels. They clamped over here, but left these open to drainage to atmosphere, to zero pressure. And what did they find? With an NRP flow rate of about 3,000 to 3,600 milliliters per minute, there was a continuous supply of blood coming down from the brain through these open vessels at 50 milliliters per minute. Now, that made them freak a little bit, and I don't want to overstate it because it sounds like a lot, but it's not really a lot, and it's unclear about whether that is enough to create any positive flow to the brain, but it validated the concerns of our community in the room, which was there's lots of potential sources of collateral blood supply to the brain during NRP. There's lots of vessels that will not be captured by ligating these arch vessels through other routes that you can get specifically to the vertebro-basilar system in the brainstem. So that issue of collateral blood supply is rampant, potentially. It may be even an increased risk if you've had previous aortic surgery or aortic obstructions like coarctation or hypoplastic arch or some aortic abnormality in which that would lead to more collateralization. So it was a proof of concept that this was a concern. And so we are working with the UK group and the Canadian group, and we put together this proposal led by Alex Manara in the UK and basically our steering committee for the DCD heart work here and a number of their surgeons there. And fundamentally, this is a little bit of a distasteful term called drain the brain. I don't like the term that much, but in actual fact, it describes exactly what is happening. The principle is if you restart circulation to the thorax and the abdomen, you clamp the aortic arch vessels, what you really should do is cannulate the cephalad ends of those vessels. Rather than just ligate, you cut off here, but you cannulate those vessels and open them to atmospheric pressure, which is zero pressure. So any blood that goes through a collateral vessel up to the vertebro-basilar system, it will go down the path of least resistance, which is retrograde back down the artery to drain in this system. They've done 12 cases of abdominal NRP with basically zero collateral flow. But the issue about this as a safety intervention in both thoracoabdominal and abdominal NRP needs to be proven beyond the N of 12 that we have in abdominal in the UK and the N of 2 in thoracoabdominal. So, about NRP, what are the preconditions to permit NRP from an ethical and logistic point of view in this country? If the surgical act of ligating or dividing the aortic arch vessels after confirmation of death before starting the pump is medically and ethically acceptable, and we agree that death in controlled DCD is defined by the permanent cessation of circulation to the brain, not just circulation, and the absence of brain perfusion can be assured in order to adhere to the principle of permanence, then restarting circulation to the thorax and abdomen does not invalidate death in DCD. Restarting the heart in the donor's body does not invalidate death, and it can be considered permissible, but it's predicated on this agreement in this country outside of the, again, ethnocentric groups that we tend to circulate with and talk to. We want to bring this outside of those groups and confirm that, in fact, this is possible. And the way we're doing that through Health Canada funding is a collaboration between Canadian Medical Association, again, to take it outside of the ICU or donation groups, Critical Care Society, and Canadian Blood Services to lead an initiative that is going to take about 2 years to really see if the community, if this is appealing and resonates with the community, that in fact there is not two types of death, cardiac and brain. There is one type of death, a single brain-based definition, and you get there because of primary brain injury, or you get there because you have a circulatory arrest specifically to the brain. So I'll just stop there, and we can't do this without an immense supporting cast of very motivated, very skilled people, and thanks very much.